A big welcome back, everyone, to another episode of the Evidence-Based Hair Podcast. I'm dermatologist and hair loss specialist Dr. Jeff Donovan. I'm also the director of the Evidence-Based Hair Fellowship Training Program. Each week I review studies that are changing how we think about hair loss. I'll introduce you to them, help you make sense of them, and give you my thoughts on how a given study just might change how we diagnose or treat hair loss. This podcast is for educational purposes and shouldn't be considered a substitute for medical advice. The month of June, we are talking about JAK inhibitors. Last week, we talked about some very interesting studies related to vaccination and infectious diseases in patients receiving JAK inhibitors. This week, we focus on a very interesting study addressing the use of generic tofacitinib. This was a study published in the Archives of Dermatologic Research titled Effectiveness and Safety of Generic Tofacitinib in Alopecia Areata. Is the generic a cost-effective option? A retrospective study. I really like this study. 2 years ago here in Canada, generic tofacitinib, the JAK inhibitor tofacitinib, became available. And we had some really big decisions to make. Do we switch our patients who are doing so well on trade name, brand name Xeljanz to generic tofacitinib? The cost savings is huge. And initially this caused quite a bit of anxiety and trepidation, both for myself and for my patients. And what has been so remarkable in the last 18 months is witnessing that all patients that have switched have really continued to do so well. Not everyone has switched, of course, and we use a range of JAK inhibitors in the clinic, not only tofacitinib, with the FDA approval and Health Canada approval of ritlecitinib and baricitinib. We're certainly using a whole different array of JAK inhibitors in the clinic. But this study set out to review the effectiveness of generic tofacitinib in treating alopecia areata. So the JAK inhibitors ritlecitinib and baricitinib are the approved JAK inhibitors. They're approved by regulatory bodies across the world, including the US FDA, Health Canada, the EMA in Europe. Baricitinib was FDA approved on June 13th, 2022 in the US. Ritlecitinib was approved about 1 year later in the United States. And we have both drugs in Canada, and these drugs are also approved around the world. Even though it's not stamped with the seal of approval, the world has been using oral tofacitinib for about 8 years, off-label, for treating alopecia areata. And in fact, in terms of the number of years of experience, there's no JAK inhibitor with more years of experience than tofacitinib for treating alopecia areata. And so the world has a lot of experience with tofacitinib. There is a large number of retrospective case-type reports. The clinical trial data is certainly not as rigorous for tofacitinib, this off-label JAK inhibitor, as it is for ritlecitinib and baricitinib. But we sure have a lot of experience with tofacitinib, and it certainly would be incorrect to say that we don't have data to support the use of tofacitinib for treating alopecia areata. There's certainly some reasonably good studies to back up its effectiveness. The tofacitinib data in the literature certainly isn't as beautiful as the elegant randomized controlled trials for baricitinib and for ritlecitinib. But we do have some data. And generic tofacitinib is now available, and it offers a tremendous cost savings over brand name tofacitinib, of which there are several brands, including Xeljanz and then an extended release form. The generic tofacitinib is just a fraction of the cost of oral tofacitinib via Xeljanz. And the generic tofacitinib, of course, is dramatically less expensive than ritlecitinib or baricitinib. And in the clinic, I have patients on tofacitinib, I have patients on baricitinib, I have patients on ritlecitinib, I have patients on upadacitinib, I have patients, very few, on ruxolitinib. And so I was very interested to read this study about generic tofacitinib for treating alopecia areata. This was a study by Jean and colleagues. The authors conducted a retrospective study evaluating the effectiveness and tolerability of generic tofacitinib in patients with alopecia areata. The study included patients with alopecia areata who received at least 6 months of treatment with generic tofacitinib, and the efficacy of treatment was determined by the SALT score. And a SALT score of 0 means no hair loss. A SALT score of 100 means complete hair loss. And in many of these studies of alopecia areata, we consider a reasonably good success a SALT score less than 20. And in this study by Jean and colleagues, the authors used that cutoff as well. This was a small study, but it had 20 patients with a mean age of 24, and the mean baseline SALT score was 87.5. And these patients were treated with generic tofacitinib. The mean SALT score here is pretty high, meaning that patients have pretty advanced alopecia areata. 2 patients had totalis, 10 patients had universalis. So these are a group of patients with pretty advanced alopecia areata, pretty significant amount of hair loss. And patients had a mean follow-up of 11.7 months. 50% received 10 milligrams, and 25% received 15 milligrams. The typical dose of tofacitinib is 5 milligrams twice a day. In the past, we were not afraid to go up to 15, 20, and even 25. But the concern about going beyond 10 was data that arose maybe 4 or 5 years ago showing that these higher doses increase the risk of blood clots. And so we are certainly not as aggressive in our dose increases as we once were. So how well did tofacitinib work in this study? Well, at the end of the follow-up period, about 95% of patients had a noticeable change in their scalp appearance. The authors found that 75% of patients were able to achieve a SALT score less than 20. And only 1 patient stopped tofacitinib because of lack of efficacy. So I really like this study. It's a small study. It's not a randomized controlled trial. But the follow-up interval was reasonably good for the types of follow-up intervals we often get in our hair studies. And a significant number of patients in this study had advanced alopecia areata. So a significant number with totalis and universalis. And the conclusion here is pretty clear, that a large proportion of patients with alopecia areata using generic tofacitinib have an improvement in their hair, and side effects were low over this period of follow-up. Most patients stuck with the standard dosing, 5 milligrams twice a day, but a quarter of patients were on 15 milligrams. So I've been using JAK inhibitors for almost a decade now, starting with tofacitinib and ruxolitinib. And what's been added to that treatment toolbox of JAK inhibitors has been baricitinib, upadacitinib, ritlecitinib. And in the last 2 years, we've been switching several patients on brand name Xeljanz to generic tofacitinib. And certainly when we first started to do this, when patients started to ask me, my pharmacist says generic tofacitinib is available. When patients would say, we've read some of your articles that this is available in Canada. Should I switch? It was certainly met with quite a bit of anxiety. What if this doesn't work as well? What happens if we take a patient on Xeljanz who's doing amazingly well, couldn't be happier, has full regrowth, and we switch them to generic tofacitinib and it doesn't work? What happens if they lose hair? Well, we've switched several patients, probably 8 or 9 patients, and all patients have done well. the follow-up interval has been pretty short. The generic tofacitinib only became available in Canada about 2 years ago, 18 months ago. And surprisingly, patients have done really well. And so when I saw this study in the Archives of Dermatologic Research, my feeling was, wow, this is great because this is such a valuable study. The main benefit, of course, of switching is the cost savings. Here in Canada, Xeljanz is about 1,706 Canadian dollars per month, the last time I checked in with our pharmacist. Generic tofacitinib is about $453 Canadian per month. And that compares to, upwards of $3,000 to $4,000 for baricitinib, 4 milligrams. So you can see that it's really quite a big decision. And I really like this study because it opens the door for us to discuss together here some of these tough discussions. And we need to make some tough decisions in this JAK inhibitor era. And for those who use only FDA-approved drugs or Health Canada-approved drugs or EMA-approved drugs, you're not going to be up for a discussion of the tough realities that exist for patients. But for those of you who do use off-label medications, then this study becomes very much a reality in your practice. And most of the drugs we use as hair loss physicians are off-label. Every single drug I use for treating FFA is off-label. Every single drug I use for treating lichen planopilaris is off-label. There's no FDA-approved drug for dissecting cellulitis. There's no FDA-approved drug for chronic telogen effluvium, trichotillomania. Being a physician is not about connecting people with drugs. It's not a matching game. It's about understanding each patient and their unique circumstances and connecting them with a treatment that meets their specific goals and objectives and is in line with their risk tolerance. And as I've said before, being a physician and a hair specialist is really about understanding what I call the SAFE principle, S-A-F-E. And the ideal treatment is safe, it's affordable, it's feasible, and it's very effective. And so the ideal treatment for the patient in front of me today is the one that aligns best with their views of the importance of each of these categories. And so when it comes to comparing JAK inhibitors, there's a lot we still don't know. We like to feel that the new JAK inhibitors are safer because they're more specifically targeting the immunologic pathways in immune cells. But there's really not a tremendous amount of great data in the alopecia areata world to support that notion. It certainly could be, and it certainly is very possible, but we really don't have great data to back that up. But we know that the new JAKs are astronomically more expensive. That is no debate. So some debate about safety, no debate about affordability. Feasibility is pretty much the same with all JAKs. And as far as effectiveness, that's open to a little bit of debate, but we don't have a huge signal that any of the JAKs are really significantly better than another. Sure, we could debate that certain JAKs may be slightly more effective than another, but not hugely different. There's no dramatic difference in JAKs yet. And that could change with more studies. That could change as new JAKs come out. And that could change as we understand specific patient populations. But in general, our current JAK inhibitors, baricitinib, ritlecitinib, tofacitinib, upadacitinib, help some patients and do nothing for other patients. And I think that's really important to keep in mind, that there's a very, very large proportion of patients that these JAK inhibitors does not help. And just this week, I explained the answer to 5 or 6 patients asking a very simple question. Why didn't a JAK inhibitor help me? Isn't it strange to you? And the answer is, it's not strange to me because JAK inhibitors don't help everyone. But they certainly help a lot of people, and they certainly are a wonderful way forward in our ability to offer treatments for patients with alopecia areata. But this SAF principle is a guiding principle in my practice, and it'll always be a guiding principle for me. We need treatments that are safe, affordable, feasible, and effective. And different patients will have different emphasis on different components of that SAFE principle. Some people emphasize safety. Some people emphasize affordability. Some people emphasize effectiveness. And for some people, the cost of the medication is definitely everything. And that's why this particular study by Jian and colleagues is so important. For some people, the cost is everything. It's the key deciding factor. If drug A causes cancer in 1 in 10,000 people, and drug B has no cancer risk, but drug A is $100 a month and drug B is $2,000 a month, well, there's many people who will choose drug A over drug B, even with the small cancer risk. But there's also many people that will choose drug B over drug A and completely reject drug A if there's any cancer risk. So the thing that's so important is there is no template for treating hair loss, or at least there should be no template. We need to understand our patients. We need to understand how they value safety, affordability, feasibility, and effectiveness. And we need to help them with the data in each of these categories so that they can make a decision for themselves. For some people, the FDA approval of a medication and the fact that their insurance covers a medication and the fact that there's a randomized double-blind placebo-controlled trial to back this up, supervised by the FDA, will always outweigh a cheaper medication that has more limited data and poorer quality studies to back it up. But not for everybody. So the SAFE principle is a principle that runs my practice. FDA approval doesn't mean complete safety. It means reasonable safety. FDA approval doesn't mean affordability. The FDA has nothing to do with affordability. FDA approval doesn't mean feasibility or ease of using a drug. FDA approval often equates to some inkling of effectiveness, but it doesn't mean complete effectiveness. And some rather ineffective drugs can and have received FDA approval. So this particular study reminds us that in 2024, generic Tofacitinib is still there in the Alopecia Areata toolbox. When I open my JAK inhibitor toolbox, sitting there is Tofacitinib, ruxolitinib, baricitinib, upadacitinib, and ritlecitinib. And other JAK inhibitors are sort of sitting there as well, but we don't have as much data with them, like abrocitinib. And more JAK inhibitors are on the way. And so I prescribe all these drugs. I have patients on Tofacitinib, Xeljanz and generic. I have patients on upadacitinib. I have patients on baricitinib. I have patients on ritlecitinib. And of course, a good proportion receive FDA-approved and Health Canada-approved drugs because their insurance recognizes that these are options that align with the approval process of their insurance companies. But why in the world would I prescribe an off-label medication? Well, because I don't believe in templates and I don't believe in robotic assignment of treatments for patients. Disease A gets drug B. Disease C gets drug D. There's no templates in my practice, and I treat patients and connect them with treatments that align with their values on safety, affordability, feasibility, and effectiveness. And if affordability is superior to safety, provided the drug is reasonably safe, and provided the drug is reasonably effective, then affordability will win out. And so once I understand a patient's risk tolerance, once I understand their insurance coverage, once I understand their lack of insurance coverage, once I understand their treatment expectations, then I can connect them with a treatment which makes sense, if that includes a JAK inhibitor at all. So I really like this study, and I appreciated very much this study by Gian and colleagues in the Archives of Dermatologic Research. Next week, we're back continuing our June theme of JAK inhibitors. Next week, we are talking about the use of baricitinib in young children, a fascinating study looking at the use of baricitinib in children 6 and under. I think one of the trends we will see undoubtedly over the next 3 to 5 years is an intensively increasing number of studies looking at the use of these JAK inhibitors in those under the age of 18. Ritlecitinib is, of course, approved for 12 and over. I think that will be the trend in our field, that we'll see more and more JAK inhibitors being studied in young patients and more JAK inhibitors ultimately approved for young patients. So we'll talk about an interesting study next week. Thanks for joining me today. It's my honor to be with you. Bye for now.